Caulfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, it's all about the evidence-based caesarean section. The evidence-based Caesar is something that comes up a lot in training, and our surgical techniques are constantly evolving. The way we do Caesars has changed over the years, and slight changes in technique are largely what has been responsible for making a caesarean section the safe procedure it is today.
Did you know that we used to think that you didn't need to suture the uterine wall? In fact, people were performing subtotal hysterectomies at the time of Caesar before any attempt was ever made to close the uterus. This was known as the Porro Technique. Actually, the first ever caesarean performed at the Women's Hospital in Melbourne was done by the Porro Technique. Walter Balls Headley did the procedure in 1888, and the mum actually named her baby after the procedure and the surgeon, Perina Balls Headley.
Perina, what a cutie, what a name. This wasn't the first successful Caesar in Australia though. That was performed by Dr. John Cook at the Alfred Hospital in Melbourne in 1885. The patient had a cancerous vaginal growth completely occluding her birth canal, and she delivered successfully via a classical section.
Now that we've covered this week's fun facts, let's get into the evidence-based techniques used in caesarean sections today. We'll start off with the pre-operative management. What do we need to do to get ready before our patient even gets into theatre?
So our typical pre-op workup would involve providing information about caesarean section antenatally, completing a consent with the patient, and ensuring we have a baseline full blood count and group and hold. An anaesthetic review is helpful to discuss the mode of anaesthetic, but also to review the patient to anticipate if there might be any difficulties with regional anaesthesia or with the airway if a general anaesthetic is required. We also want to review and confirm the indication and timing of the caesarean section. If the Caesar was booked because the baby is breech, it's a good idea to confirm that the baby is still breech, lest you do an unnecessary caesarean section on a cephalic baby. A woman is usually advised to fast from solids for 6 hours and to have clear fluids only until 2 hours prior to the Caesar. She may also be given sodium citrate and famotidine to raise the pH of gastric fluid to make it less acidic and reduce the risk of aspiration if a GA is needed. We top all of this off by making sure we have completed our WHO surgical safety checklist to ensure we are operating on the right patient.
I haven't seen anyone be given sodium citrate or famotidine. Do anaesthetics give that, or are we supposed to?
Usually the nursing staff will do it on the ward as part of their pre-op workup.
Yeah.
Ah, that makes sense.
Or like,
Excellent.
in the pre-op bay.
Okay, right. So we can finally move our patient into theatre. Now, we want to set the scene here. It's a birth, a time of joy and often anxiety for our mothers-to-be. Theatres can feel really clinical, so it's important we do what we can to make it as welcoming as possible. Little things like having her partner in the room to support her while she gets her spinal and minimising unnecessary conversation can go a long way to improving the birth experience. Also, music. I can't sing. In a meta-analysis of RCT, music during caesarean sections was associated with decreased intraoperative anxiety. We therefore recommend asking patients their preference for having or not having music and what kind of music they would like during their Caesar. A really good Spotify playlist is called Caesarean Section Perfection, made by one of our own Australian RANZCOG trainees, Anna Walsh. If you have your own C-section playlist, please comment on our Instagram or Facebook page so we can share the love.
Once the spinal's in, we would usually position our patient with a slight left lateral tilt to reduce the compression of the gravid uterus on the inferior vena cava, and then get ready to insert the catheter. Interestingly, there's no high-quality evidence to suggest that a catheter is absolutely necessary, although if you've ever had to do a Caesar without a catheter, you'll know how annoying it is to have a full bladder. While you're inserting the catheter, it's also a good time to do vaginal prep. Vaginal prep with betadine or chlorhexidine has been shown to reduce the risk of endometritis from 8.1 to 3.4%, post-op fever from 11.4 to 7.1%, and wound infection from 5.4 to 4.1%. This data comes from a meta-analysis published in AJOG MFM in August of this year, which also showed that 1% povidone iodine was the most effective prep of choice. The benefits appear to be greatest in patients in labour or with ruptured membranes. However, the WHO recommends vaginal preparation for all women undergoing caesarean section. Whilst the exact technique is unclear, Most studies used vaginal prep for at least 30 to 60 seconds. In our practice, we typically use a betadine-soaked lollipop or swab on a stick to clean the vagina, then leave the swab in the vagina before performing catheterization. The swab's then removed after the ADC is inserted, allowing enough time for the prep to exert its effect. Alcohol-based antiseptic solutions should be absolutely avoided, as they can cause irritation of the vaginal mucosa, as I'm sure you can imagine.
Yeah, ouch. Next, we want to think about pre-operative antibiotics. Pre-operative antibiotics have been demonstrated to reduce the incidence of post-operative wound infection and endometritis by 60 to 70%. There was a study that looked at whether antibiotics administered at cord clamping is just as effective as pre-operative antibiotics, but it looks like pre-op antibiotics are the way to go, as this resulted in 30% less infections when the antibiotics were given before the surgery compared with at the time of cord clamping. This means that the antibiotic should be administered within 60 minutes before the skin incision, and ideally at least 30 minutes before skin incision. I don't know about you guys, but this seems to be something that is done quite poorly at most facilities I've worked at. Most patients tend to get the antibiotics when they're in theatre, only a few minutes before the skin incision.
Yeah, I've definitely noticed that as well. Maybe that's something we could do better. And there's an audit idea. So, Anne, which antibiotics should we be giving?
We typically give 2 grams of cefazolin if the patient's weight is less than 120 kilos, and 3 grams if the patient's weight is equal to or above 120 kilos. However, you can also base the dose on BMI. Queensland clinical guidelines recommend giving 3 grams of ivcefazolin to women with a BMI over 30, whereas King Eddie's Memorial Hospital recommends 3 grams of cefazolin if the BMI is over 40. We suggest you refer to your local guidelines. If the patient is known to be MRSA colonized, then adding vancomycin 1 gram or 1.5 grams if the patient is over 80 kilos. If the patient is allergic to penicillin, then clindamycin 600 milligrams and gentamicin 2 milligrams per kilo should also be given.
Far out. I didn't realize you had to give gentamicin as well as clindamycin.
Yeah, so clindamycin has really good coverage against gram-positive and anaerobic organisms, but you need to add gentamicin to add that gram-negative coverage too.
Interestingly, UpToDate also recommends a single dose of azithromycin, 500 milligrams IV, for patients in labour or with ruptured membranes, based on a 2016 study that showed that the addition of azithromycin to standard antibiotic prophylaxis reduced the rate of post-op infection from 12% to 6%. Ranscog states that 500 milligrams of azithromycin may be considered at caesarean sections performed during labour or at least 4 hours after ROM. However, a strong recommendation in favour of routine use is not yet warranted, given the concerns around the external validity of the paper, inducing resistance to azithromycin, and possible effects on the establishment of the fetal microbiome. Ranscog also suggests that a second dose of cefazolin is appropriate for patients in whom a Caesar extends beyond 3 hours. Surgical prophylaxis should also be given regardless of whether the woman was receiving intrapartum antibiotic prophylaxis for group B strep.
Skin preparation with alcohol-based chlorhexidine also reduces the risk of infection. There is a lack of evidence to recommend a specific concentration of chlorhex. However, most trials use 2% gluconate in 70% alcohol. If alcoholic chlorhexidine is not available, povidone iodine can be used, although it is not as effective. One study comparing chlorhex and betadine showed that chlorhex was associated with less infections, with a relative risk of 0.72. The trick with alcoholic chlorhex is to let it dry by evaporation, not only because that's how you get maximum efficacy of the antiseptic, but also because alcohol-based prep is highly flammable and can ignite if diathermy is used while the solution is still wet. It can take over a minute for the antiseptic to dry, so you really need to be patient. Drying the incision site after application with a swab or a sponge reduces the efficacy of the antimicrobial solution and is best avoided. You also need to make sure that the drapes are not saturated with alcohol, or that the prep hasn't formed a pool underneath the woman before starting surgery.
Hair removal is not required, and studies have shown no difference in the rate of surgical site infection in those who'd had hair removal prior to surgery versus those who didn't. That said, removing the dressing from a hairy area can be quite painful. So if you do need to remove hair, use clippers rather than a razor to allow application of adhesive dressings. Shaving with a razor actually increases the risk of infections. There's also some evidence that non-adhesive drapes should be used instead of adhesive drapes, as they are associated with a lower rate of surgical site infection. And by adhesive drapes, we're referring to sticky drapes that cover the entire abdomen, which you then make your incision through.
Ah, okay, that makes sense. Not the ones with the open area in the middle that I've seen.
No,
cool.
That's fine.
Okay, so time for a quick recap. Our pre-operative management includes confirming the indication and timing of caesarean section, ensuring we have a written consent, collecting a pre-op FBC and group and save, arranging an anaesthetic review, fasting from solids for 6 hours and clear fluids for 2 hours, sodium citrate and H2 antagonist like famotidine or ranitidine to reduce gastric acid acidity, and completing the WHO surgical safety checklist. Once we're in theatre, we want to have some music playing of the patient's choice if they want, trim rather than shave the hair, consider a catheter, vaginal prep with betadine, skin prep with chlorhexidine, using non-adhesive drapes if they're available, positioning the patient in the left lateral tilt position, and giving preoperative antibiotics, 2 grams of cefazolin or 3 grams based on a weight or BMI, adding vancomycin if they have MRSA, and giving clindamycin and gentamicin if they're allergic to cefazolin. Alrighty, let's move on to our intraoperative techniques. What type of skin incision should we be using?
Typically, we would perform a transverse skin incision since it has a better cosmetic appearance and less hernia formation than a vertical midline incision. Although it's important to note that some developing countries still practice with a vertical midline incision. The 2 most common transverse skin incisions are the Pfannenstiel and the Joel-Cohen incision. The Pfannenstiel incision is a low, transverse, curvilinear incision 2 to 3 centimeters above the symphysis pubis, and the Joel-Cohen incision is a straight, transverse incision 3 centimeters below a line that joins the anterior superior iliac spines. Now, it's important to note that here we are referring to skin incision only. When we talk about entry techniques, we are actually referring to a series of steps beyond a simple skin incision, almost a guide on how to do every single step of the caesarean section. The most common caesarean entry techniques include the Pfannenstiel technique, the Joel-Cohen technique, and the Misgav-Ladak technique.
Ooh, alrighty. So what's the difference between these techniques?
The Pfannenstiel technique consists of a Pfannenstiel incision, remember a curvy linear incision 2 to 3 centimeters above the pubic symphysis, followed by sharp dissection of the subcut layer and sheath. A sharp incision is made on the uterus, followed by blunt entry. The placenta is removed manually, and the uterine closure is made by an interrupted single-layer closure. The peritoneum is closed and the fascia is closed in an interrupted technique, followed by continuous suturing of the skin. The Joel-Cohen technique involves a Joel-Cohen incision, remember a transverse incision 3 centimeters below the ASIS, followed by sharp dissection of the subcutaneous tissue in the medial most 3 centimeters. The lateral subcut tissue and fascia is then stretched bluntly, and the peritoneum is also entered bluntly. The uterus is incised, and the incision is extended bluntly laterally by 2 fingers. The placenta is delivered spontaneously, and the uterus is closed with a single interrupted layer. The peritoneum is not closed, and the fascia is closed in an interrupted technique, again, followed by continuous suturing of the skin. Finally, we have the Misgav-Ladak technique, otherwise known as the modified Joel-Cohen technique. This technique involves a transverse incision 5 centimeters above the pubic symphysis, sharp superficial incision of the fascia by blunt dissection of all abdominal layers. The placenta is removed manually, the uterus is closed with 1 running layer, the peritoneum is not closed, and the fascia is closed continuously. The skin is typically closed with a mattress suture. There's also a modified Misgav-Ladak technique, which uses a Pfannenstiel incision, blunt dissection of all abdominal walls, spontaneous delivery of the placenta, closure of the peritoneum, and continuous closure of the skin.
Oh, so many techniques. How are we supposed to know which one to use? I feel like everyone meshes them all together.
I know. So the Joel-Cohen technique actually has a few short-term advantages over the fan and steel entry. So that's talking about more blunt dissection rather than sharp entry. So it results in less fever, pain, analgesia, and blood loss, and is also associated with a shorter operating time and length of stay. Despite this, most of us prefer the fan and steel incision because it is lower on the abdomen and has a better cosmetic appearance. And the advantages, although statistically significant, are not that clinically important. For example, the mean reduction in blood loss between a Joel-Cohen and a fan and steel technique is only about 50 mils.
Trying to memorize the nuances between each different technique is a bit tricky, so we'll pop a table on this week's Instagram summary to help you work it out. But basically, the fan and steel technique involves a curvilinear transverse incision 2 to 3 centimeters above the symphysis pubis, followed by sharp entry. And the Joel-Cohen entry uses a transverse incision 3 centimeters below the acis, followed by blunt dissection. The modified Misgov-Lutter technique uses a fan and steel incision with otherwise blunt entry. So let's break down the steps of a Caesar in a little more detail. So far, we've done our skin incision. What's next?
Once we get to the subcutaneous fat layer, we typically use a scalpel to incise the subcut tissue in the middle 3 centimeters of the wound, and then extending the opening laterally with fingers. A small transverse incision is made in the fascia medially with the scalpel, and then either extended laterally with scissors or bluntly with fingers. Rectus muscles typically don't need to be dissected off the rectus fascia, and non-dissection may actually result in higher post-operative hemoglobin and less pain. The rectus muscles are then separated bluntly. We try to avoid transection of the muscles. This is called the Maillard technique because this can reduce muscle strength in the early post-operative months. Then we get to the peritoneum, which can be entered bluntly or sharply if you prefer.
So, fun fact, there is actually something called an extraperitoneal Caesarean section. Now, most people, including us until recently, had never heard of this before. But this is a technique that was previously used before the advent of antibiotics to try and reduce the risk of intraperitoneal infection. This technique avoids exposure of the peritoneal cavity to blood, amniotic fluid, vernix, and mechanical irritation, and can reduce intraoperative nausea and vomiting, as well as postoperative pain. It's being increasingly practiced, particularly in France, where it is referred to as the French ambulatory Caesarean section.
My brain just cannot fathom this. An extraperitoneal.
Yeah.
It just makes no sense. There's a baby inside the peritoneum. But anyway, how do you even do it?
Yeah, so it took me a while to get my head around this as well. So basically it starts with a fan and steel incision on the abdomen, and then you make an inferior vertical incision at the aponeurosis. And instead of entering the peritoneal cavity, what you do is you use a retractor to push the bladder, which is often not catheterized, medially. And then you perform an extraperitoneal hysterotomy, leaving the peritoneal cavity intact. It's actually quite an interesting technique, and I found a really good video of it. So if you want to get your head around it and see how this is actually done, we'll put the link on our Instagram and you can watch it because it does make sense once you've seen the video. The other thing I found interesting about it. Yeah?
Oh, sorry. So is it under the bladder?
Yeah, so you kind of push the bladder to the side and then make an incision behind the bladder rather than entering the peritoneal cavity.
Why not? Maybe this will be what we're all doing. It's very creative.
Well, there are some proponents of it in France, and they say that you can come along and watch and learn how to do it. But I guess you probably have to speak French.
We could go on a trip.
Oh, the closure of the uterus? They actually just do a purse string closure.
Ooh,
so that you have
cute.
a small hysterotomy rather than securing the angles. Yeah. Interesting.
Yeah.
All right, so back to the standard Caesarean section. Let's talk bladder flaps. This is something that I think most of us routinely do. There's something soothing about knowing that the bladder is down and out of the way of our incision. But did you know that you can actually omit this step? Meta-analysis demonstrated that skipping the bladder reflection does not increase the risk of bladder injury or blood loss, and it reduces the incision to delivery time by about 1.3 minutes. Obviously, if the bladder is pulled up above the intended uterine incision, or if there's any risk of uterine incision extension, for example, in the case of a fully dilated Caesar, then it might be safer to create a bladder flap. But if the bladder is already down and out of the way, then you don't really need to reflect it.
I've actually found that omitting the bladder flap results in less of that bladder base ooze that you tend to get once you've closed the uterus. You know how sometimes you're always chasing a small bleeder down there, and sometimes someone might put some fibrillar or something. So I'm definitely a fan of not creating a bladder flap if you don't have to.
That's a good point. Alrighty, so we're finally at the uterus. We're really dragging out this procedure, aren't we? I swear we're much faster when we're doing it. Now, for our hysterotomy, we typically perform a transverse lower segment uterine incision, otherwise termed a Monroe-Kerr incision. You can also do a vertical incision called a classical Caesarean. Transverse incisions have less blood loss, less need for bladder dissection, easier repair, and a lower risk of uterine rupture in future pregnancies. It's the best incision for patients who are planning another pregnancy. The downside of a transverse incision is that you can't extend the incision laterally without risking injury to the major blood vessels. If you did need to extend the incision, then you would need to perform either a T or a J incision.
We start the lower segment uterine incision by making a small 2 to 3 centimeter transverse incision with the scalpel and then entering the uterine cavity bluntly with your index finger. The uterine incision is then extended using blunt extension in a cephalocaudal direction in order to reduce the risk of unintended extension laterally and into the uterine vessels. Cephalocaudal stretching has been shown to reduce blood loss, postpartum pain, and need for transfusion, comparing when you extend the uterine incision with scissors.
Once our baby is born, then we would typically do delayed cord clamping for at least 30 to 60 seconds or until the cord stops pulsing. Obviously, if the mother is bleeding or if the baby needs resuscitation, then this would need to be cut short. Ideally, the baby should be placed on the mother's legs below the level of the uterus in order to obtain the most benefit from delayed cord clamping. Although that said, there is still a benefit to the baby in doing delayed cord clamping while showing the parents the baby, compared to not doing delayed cord clamping at all. And if you think about it, at a vaginal birth, we typically place the baby directly onto mum's chest above the uterus rather than on the bed between her legs. I prefer to do delayed cord clamping while holding the baby and showing the parents. I just find it helps keep the baby warm, and it also aids bonding with the new parents. It's the first time they get to see their child. Better yet, if you work at a facility that supports maternal assist Caesar or the ability where you can deliver a cesarean section, deliver the baby straight onto the mum's chest, that might also be helpful in reducing the effect of gravity. Now, I usually do discuss both options with the baby regarding cord clamping, so either placing the baby on the legs or holding the baby up, and I let them decide. Obviously, if the baby is extremely preterm, then I want to maximize the cord blood going to the baby, so I would aim to leave the baby below the level of the uterus. This is personal opinion, not guideline recommended, by the way.
Right, yeah.
Delivery of the placenta should be done with controlled cord traction rather than manual removal. CCT results in less endometritis and blood loss when compared with manual removal of the placenta. Uterotonics should be given before removal of the placenta and can either be oxytocin 5 units IV or carbitocin 100 milligrams IV over 1 minute. A 2019 meta-analysis comparing carbitocin to oxytocin showed that compared with oxytocin, carbitocin is associated with a reduction of ppH over 500 mils. It reduced the use of additional uterotonics and less average blood loss, although it makes no difference to ppH over a litre, maternal deaths, ICU admissions, blood transfusions, or the mean change in hemoglobin levels measured before and after birth. Now, the cost of carbitocin is about $36 compared with $4 for oxytocin. But when you consider the reduced costs associated with less ppH, it really does work out to be cost effective. So somebody tell me this. When I'm at a Caesar and I ask for oxytocin, why do the anaesthetists constantly give me 2 units of oxytocin instead of the full 5?
Oh my God, it's so annoying. You ask a Synto expecting the patient to receive the full 5-unit bolus as recommended in obstetric guidelines, and then you hear 2 units of oxytocin given. Why? So I have looked into this after having many debates with the anaesthetist in theatre, and I think the problem comes from separate guidelines. I found a 2019 article published in the journal called Anesthesia titled International Consensus Statement on the Use of Uterotonic Agents During Caesarean Section. Now, this guideline states a few points. Firstly, standard recommended doses are higher than required, with the potential for acute cardiovascular effects. Secondly, there are significant differences between dose requirements during elective and intrapartum caesarean section. the recommended doses of oxytocin may have to be increased in women with risk factors for uterine atony. And here's the kicker. The suggested dosing for an elective caesarean section is a 1 unit bolus of oxytocin or 3 units of oxytocin over 30 seconds for an intrapartum caesarean section, followed by an oxytocin infusion at 2.5 to 7.5 units per hour. And then if more uterotonics are required after 2 minutes, you can give a further dose of 3 units over 30 seconds. Now, this is clearly in contrast to obstetric guidelines and way more complicated. RANSCOG, ACOG, the Green Top guidelines all recommend 5 to 10 units of oxytocin IV or 100 micrograms of carbetocin. But it's interesting to note that the doses recommended in obstetric guidelines are based off clinical recommendations and are not actually based off randomized double-blind trials. I think what is really needed here is a consensus guideline, but not just from the anaesthetic team. Anaesthetics and obstetrics need to get together and make a universal recommendation so we can stop having this annoying conversation in the operating theatre. We have no problem with a lower dose of oxytocin at the time of caesarean section if it's being used for prophylaxis. However, sometimes we switch quite quickly from prophylactic management to active management in PPH, in which case we really want that full dose of oxytocin before working through our other uterotonic agents. If we're looking at doing a Bacri or a uterine compression suture, then I want to be sure that I've maximized my medical management of PPH first.
Yeah, I really miss carbetocin when you go to a hospital that doesn't have it. So good.
Yeah, there's no debate with carbetocin. It's 1 dose.
I know,
Bring
it's
it
so
back.
Good. Now this brings us to uterine closure. In general, it doesn't really matter whether you suture the uterus in situ or if you prefer to exteriorize the uterus for closure. If you do exteriorize, there's an increase in intraoperative nausea and vomiting, as well as need for more analgesia at 6 hours post-op, but no major differences in any other parameters. Most clinicians will perform a double-layer closure, which results in increased residual myometrial thickness compared to a single-layer closure. Although this doesn't appear to have any impact on the rates of uterine rupture, niche formation, or development of adhesions or gynecological issues, and therefore a single unlocked uterine closure can also be performed. The peritoneum typically does not need to be closed. There was a meta-analysis that demonstrated that non-closure of the peritoneum reduces operative time by about 6 minutes, has less cost, and does not increase the rate of adhesions at subsequent caesarean. That said, there has been another systematic review that demonstrated that closure of the peritoneum did result in less adhesion formation. I was taught not to close the peritoneum, and most obstetricians I work with also don't close the peritoneum, although you'll come across someone every now and then who does. The fascia is typically closed with an O or 1 vicryl or PDS with a continuous non-locking suture. In a meta-analysis of RCTs, suture closure of the subcutaneous adipose layer reduced the risk of subsequent wound disruption by 1/3 in patients with a subcutaneous tissue depth of more than 2 centimeters, but not in those of less than 2 centimeters. The idea is to close the dead space to prevent accumulation of serum and blood, which can lead to a wound seroma or hematoma and subsequent wound breakdown. Skin should be closed with a subcuticular absorbable monofilament suture to reduce wound complications and improve cosmesis.
Okay, so it's time for a summary of our evidence-based recommendations. Firstly, a modified Joel-Cohen entry technique, blunt entry technique, avoid a bladder flap, transverse lower uterine segment incision, cephalocaudal stretch of transverse uterine incision, controlled cord traction for delivery of the placenta, carbetocin for uterotonic, intra-abdominal closure of the uterine incision, non-closure of the peritoneum, closing the subcutaneous layer if it's greater than 2 centimeters, and suturing skin with a subcut continuous absorbable monofilament suture.
Now, just to wrap up, there have been so many trials and systematic reviews relating to the evidence-based caesarean section, but the most commonly cited trial is the Coronis trial. So the Coronis trial was published in The Lancet in 2013, and this was a randomized control trial that examined 5 elements of the caesarean section technique in intervention pairs. So blunt versus sharp entry, exteriorization of the uterus versus intra-abdominal repair, single versus double layer uterine closure, closure versus non-closure of the peritoneum, and chromic catgut versus polygalactin 910 for uterine repair. Basically, the trial and its 3-year follow-up showed insufficient evidence to favour one technique over another, suggesting that any of these surgical techniques is acceptable. It's important to know that there is not one right way to do a caesarean section. So just because you see someone doing something outside of this guideline does not mean they're doing a caesarean section wrong. However, standardizing your technique can have a few benefits. So firstly, if you standardize your technique of caesarean sections within institutions, it's been shown to improve safety, efficiency, and effectiveness in healthcare delivery because everyone does everything the same way. Scrub nurses know what sutures to get at, etc. Secondly, surgical training amongst O&G juniors becomes more consistent across hospitals and regions. You don't get the resident or the registrar saying, "Oh, sorry, how do you close a uterus again?" or "What suture do you use for this?" Everybody just knows what they do. And thirdly, standardization would really strengthen future trials on caesarean delivery technique because it would minimize the potential for aspects of the surgery which are not being studied to bias results. So if everybody does a caesarean section the same way, if you're going to study something, just change one thing and then you know whether that one thing is making a difference or not the 5 other ways that you do a caesarean section differently.
All right. Well, thanks again for listening to this week's episode of The Uterine Sound. Check out our Instagram, The Uterine Sound, or our website, theuterinesound.com. As usual, if you'd like to make a comment on this week's content, feel free to email us at theuterinesound@gmail.com. We'll talk to you next time.